So in our last two sessions, we have talked about cases where the patient has too little immune response, either by virtue of a genetic inherited disorder or by virtue of an acquired disorder such as HIV/AIDS. Now we're ready to look at the opposite side of the coin. What happens when a patient has too much of an immune response? And realize that these problems can be just as damaging and ultimately will have the same need for therapy because of the fact that you either have to make certain that the patient is never going to see that particular molecule or immunogen again, or one has to try to cut down on the immune response by ablating it. So we divide the hypersensitivities, as these are called, into four categories, each one of which is distinct because of the mechanism by which it is aroused. So realize each one of these requires an initial or sensitizing exposure, after which I will typically have increasing levels of symptoms ensuing after that, because as you know, the immune response gets stronger and faster and better at what it does. So imagine the problem if I have the response being made against my own tissues. We refer to those types of hypersensitivities as autoimmune diseases. And the problem, of course, here is because there has been some failure of self-tolerance, and because the immunogen is some part of you, the only thing that's going to make your immune response happy is when it gets rid of you. So if you understand what I'm saying, these are very nasty diseases, many of them, and require lifelong immunosuppression in order to adequately deal with them. Now let's look at how they all begin. Type 1 hypersensitivity is also known as immediate hypersensitivity or atopic allergy. Okay, this is the type of hypersensitivity that is really a misplaced anti-Godzilla response. Remember, in that scenario where the thing I need to get rid of is larger than any of my immune cells, I will use a flamethrower approach that involves making IgE and having that bind to mast cells and basophils. Well, when I mount this response against something that's not the size of Godzilla, then the problem arises that now I'm holding that flamethrower on my own tissues, and the result is bound to be damaging. Type 2 hypersensitivities can be mediated either by IgM or IgG, okay, not IgE, and they are mounted against one's own cells or tissues, the whole cell, the cells in a particular tissue. And once I have antibodies against my own tissues binding in those tissues, I will have a cascade of complement activation, of opsonization, and phagocytosis and inflammation in that area that reflects the fact that the antibody has bound to my own cells. Notice all of these are autoimmune, and all of them will manifest an expression that is localized in nature because of the fact that the antibody is specific for a particular cell. The place where I see the damage is going to be wherever that cell resides. My type 3 hypersensitivities are caused by immune complexes, so I can also call these immune complex hypersensitivities. But the distinction here is that the antibodies, which again may be M or G, are against proteins or components of cells, not a whole cell. So when the production of the complexes, the antigen and the antibody, circulates, the spleen is tasked normally to remove them from the blood via complement opsonization. But when there's too much for that to work, when the spleen is overwhelmed because there are so many of them, then what happens is I have spillover of those complexes and they bind in the small to medium-sized vasculature of the body, and the result is the same activation of damage as I saw with the type 2s, namely complement, opsonization, inflammation. But it's going to happen anywhere I have blood vessels of a certain diameter. So I'm going to see this as a system-wide problem, in spite of the fact that it's antibodies plus complement causing the problem, just as it was with type 2s. So realize this is not going to be a tissue or organ-specific damage. This is going to be everywhere, whereas the type 2s were very localized. Type 4 hypersensitivity is also known as delayed type hypersensitivity, and you may have seen that abbreviated as DTH, okay? That is to imply to you that this is not going to be seen on the same time frame that I would see particularly with the type 1. And it's because of the fact that it's a manifestation of the T helper 1 arm of the nirvana diagram. In other words, an APC1 communicating to a TH1 and then turning on the effector cells of CMI, which may be either macrophages in that APC1, TH1, APC1 loop that I see with facultative intracellulars, or it may be a cytotoxic T cell that ends up being the one that's turned on. It's said to be delayed because it takes 48 to 72 hours in repeated occurrences in order to see the level of cellular communication and traveling and so forth that you need for these very complex cell-mediated interactions. But you shouldn't be surprised, I hope, that many of these end up becoming mixed hypersensitivities. Because once I go down the M1-TH1 pathway, I can then spill over in the debris that is caused into an M2-TH2 and antibody response. So it's not at all surprising to eventually see autoantibodies being produced against the debris of the cells that were killed in the first wave of the cell-mediated effector functions. Now, going through these in sequence, type 1 hypersensitivity is very common in our society, much less so in the developing world, because if your body is kept occupied as it should be, handling parasites with the production of IgE, then you don't have time in order to waste your effort making IgE against things like dust or dander or pollen. But the fact that it's very common in the United States means that it becomes a tremendous pharmacologic question, because in most cases we manage these problems pharmacologically. The examples, of course, hay fever, anaphylaxis to drugs, bee stings and other insect stings, and eventually asthma in long-term exposure and damage. Now, the first exposure to the allergen is asymptomatic, but remember, I'm moving through the nirvana diagram on the right-hand side. My alternatively activated APC stimulates a T helper 2, and the signaling tells it to make interleukin 4 and 13. Those molecules will act on B lymphocytes and stimulate them to isotype switch so that IgE is made. Once IgE is made, it has a very short half-life in the plasma, but when it binds to mast cells and basophils, unfortunately, it ends up sort of being the gift that keeps on giving, because it will remain on the surface of those cells waiting for an additional exposure to that immunogen. And when that happens, then cross-linking of those molecules is going to cause the cells to degranulate and release preformed mediators. Now, Notice we have a monoclonal antibody that acts to sop up any free IgE it finds. So you'll see that I will mention the drugs we have in use. Some of these problems are difficult to manage, and of course, if possible, one of the best ways to manage type 1 hypersensitivities is to cut the exposure out of the patient's life. If it's a peanut allergy, you keep them away from peanuts. If it's a dog allergy or a cat allergy, you keep them away from those. But unfortunately, that is sometimes difficult in our relatively complex societies. Now, when we talk about what happens with degranulation and release of mediators, we sort of have two waves of problems. We have the immediate granule contents, which are liberated as the cells explode, and then we have those things synthesized at the site where the granule release has happened, which are largely products of the arachidonic acid cascade. Because remember, anytime you injure a phospholipid membrane, you end up causing the activation of that cascade, and you get all of those eicosanoids as a result. So I tend to see the results of my granule contact release happening seemingly instantaneously with subsequent exposures. But in the case of the late phase response, as we see it, this can occur, say, in 4 to 6 hours after the initial granule release. Now, as I said, in my opinion, the way they're most likely to test you on this on the exam is with pharmacology, because at each step, not only should you know what the given product produces as far as its action in the area, but also if there is a drug that we can use to inhibit that particular process. So histamine, of course, is the major indicator, the major cause of vasodilation and intestinal hypermotility. We deal with it by inhibiting release. Tryptase is a common released material that causes a tremendous amount of tissue damage and complement activation, and is a major player in asthma and damage in the lung. It's considered to be a marker for the presence of eosinophils in an area, but notice we don't have too many ways to deal with that at present. The prostaglandins and leukotrienes, as we said, we're going to handle those by going after the arachidonic acid cascade, but bronchoconstriction from PGD2, mucus secretion and endothelial cell adhesion for diapedesis in the case of leukotriene C4. We have a variety of different agents that work either against the chemical itself or against the receptors, as you see. Platelet activating factor, eosinophil chemotactic factor. Realize these are going to bring white blood cells into the area, and these, as well as cytokine synthesis, are managed by giving corticosteroids. Tumor necrosis factor increases vascular permeability, again managed with steroids. And major basic protein, which, if you'll recall, is the granule content primarily of eosinophils, is the thing that can be toxic when produced in the tissues. It's normally designed so that it will destroy the cuticle of a helminth, but it has been shown now to have a major role in the long-term problems that we see in asthma chronically. The type 2 hypersensitivities, as we said, caused by autoantibodies against your own cells or tissues. And so I'm going to divide these in my discussion between those that are said to be cytotoxic and those that are said not to be. Well, if it's not cytotoxic, as you'll see, what we're talking about is really an antibody that binds to a cell and then changes the activity of that cell. It alters its normal function. but realize these begin by the antibodies binding to the cell or tissue, and the binding is generally visualized either by immunofluorescence or by electron microscopy as being a very linear deposition to the tissue. So if my tissue has epitopes on it, which are somehow causing my body to make an immune response against them, then I will be able to see the antibodies against them depositing linearly on the surface of that tissue. And I'm making that point because of the fact that in immune complex disease, as you'll see, because those are floating antigens and not tissue bound, you'll notice that I have accumulations of those complexes in a more jumbled or granular deposition. So starting off with the type 2s that are cytotoxic, I've arranged them in general from left to right according to the ones that they prefer to ask. And honestly, their very favorite is hemolytic disease of the newborn. Okay, we don't see a lot of this anymore because it is a point of medical management that we're very careful during pregnancy to ascertain whether or not it's likely for a mother to have a reaction against her fetus. But generally, we don't see the problems in the first pregnancy. It happens in an Rh negative mother when she's pregnant with an Rh positive fetus. And any subsequent pregnancy, if not protected against, as we'll talk about shortly, any subsequent pregnancy, the problem will become progressively worse because, of course, we're stimulating her immune response repetitively with antigens that she has never seen before, and she will make an antibody of IgG isotype. And you should know that IgG is actively transported across the placenta. So I can have everything leading up to fetal death, including hemolysis, anemia. If the child is born alive, we refer to it as hemolytic disease of the newborn. And of course, that necessitates a whole body transfusion, often several repetitive bouts of that, in order to get rid of all of the maternal antibodies binding to the fetal cells. Now, we diagnose this with what we call a Coombs test, and I will talk about those in the final chapter of immunology that we'll do. But basically, it is a test to detect immunoglobulin against the Rh factor, okay? We also treat this with repetitive therapies of RhoGAM, which is actually a trademarked name. RhoGAM is a preparation of immunoglobulin against Rh. We're giving the mother at the termination of any pregnancy what we don't want her to make. The idea being that if I can prevent her from becoming sensitized during exposure to those fetal red cells, then I can stop her from making an immune response of her own. Now, as you might imagine, this happens with diminishing effectiveness depending on how many pregnancies there have been. But as a general rule, OBGYNs will advise women that beyond 3 pregnancies, even with institution of RhoGAM, it becomes progressively more difficult to stop the woman from making antibodies against her fetus. Next, we have rheumatic fever. Quite frankly, we do not see rheumatic fever in the United States anymore. The reason being that we are quite aggressive in therapy against streptococcal sore throat. But remember, the mechanism is still testable as a principle. So something in the cell wall of Strep pyogenes cross-reacts with antigens in your own myocardium. And that molecular mimicry between those two causes you to start making an immune response against the one, which then overlaps with your own tissues. So I develop myocarditis from inflammation and complement activation in the area. Also can see arthritis as well. I diagnose it again by finding the antibody, the anti-streptolysin O titer. Anything greater than 200 is considered diagnostic, and I manage with anti-inflammatories. If they're going to give you a question of rheumatic fever on the exam, they're going to have to tell you that it is an immigrant patient because, as I said, we don't see this in the United States. Goodpasture syndrome is a case where the patient make antibodies against their own type 4 collagen. And if you remember, that is found in the basement membranes of your lung and kidney. So the place where the antibody binds and activates complement and causes inflammation is going to be in those lungs predominantly. I diagnose it by finding those anti-basement membrane antibodies, and I treat with steroids and cyclophosphamide. The transfusion reaction is one of antibodies against ABO blood glycoproteins. And if you notice, it's the one case where I've got an IgM antibody that is responsible for this. The reason being that each and every one of us has normal flora in our intestine who have glycolipids on their surface, which are reminiscent of the glycoproteins on the surface of our red blood cells. Now, when I say the normal flora glycolipids are there in the intestine, realize that is a sugar-fat combination. There's no protein there. So the molecule that stimulates the production of the antibody is not capable of stimulating T cell help and isotype switching. Now, each and every one of us will have IgM antibodies against those molecules that are similar to cells we don't have in our own body. That was awkwardly said, but to say it more delicately, if I am an A blood group individual, I would never make antibodies against A blood group similar glycolipids because of the fact that those would bind to my own cells and cause an extremely dangerous situation. But I will make antibodies against those glycolipids that resemble blood groups that I don't have. And so these are naturally occurring in a patient. And the reason why we are so careful with transfusions is because we don't have to have a sensitizing dosage in this case. Our normal flora cause us to make those IgM isohemagglutinins. And so we have to simply be careful that we do not expose a patient to a blood group against which they are already sensitized from their normal flora. Now, needless to say, this can cause a very dangerous hemolytic reaction. And don't be confused here. Realize we're still talking about cells against which the reaction is occurring. In spite of the fact that it's happening in the bloodstream, which might make you think it's a circulating immune complex problem, we're talking about whole cells here, whole red blood cells bound by those isohemagglutinins and causing the reaction that we see. Finally, we have idiopathic thrombocytopenic purpura, where we have the patient making antibodies against their own platelet membrane proteins. I put this furthest to the right because honestly, I think it's probably the least likely of the questions. It wouldn't be difficult to project that if I have antibodies against my platelets, I'm going to have bleeding into epithelia and mucosa because of the dyscrasia of the normal clotting process. So I treat with steroids. Could be asked. I just don't think the principle is all that interesting from an immunological perspective. Now, if you notice, the non-toxic cytotoxic type 2s are divided out here. Again, we're talking about an antibody against your own cells or tissues, but in this case, for whatever reason, complement activation, lysis, opsonization, and inflammation are not primary results of that antibody formation. In Graves' disease, the problem is that I have an antibody against my own thyroid-stimulating hormone receptor. And if you think about the way the thyroid is supposed to work, realize when that receptor site is occupied, the thyroid cell is supposed to secrete T3 and T4. When the receptor site is not occupied, it's supposed to get a chance to relax. So it's an on and off hormonal signaling in that scenario. Well, if I make an antibody that occupies that receptor site, the difference with antibodies is they don't let go. And so I have constant stimulation of the thyroid to produce T3 and T4. And so what happens over time is that the thyroid cell simply becomes exhausted as it can no longer keep up with that increased demand. Myasthenia gravis is a complementary concept, but now we're talking about antibodies against the acetylcholine receptor. So in this scenario, I'm going to cause the motor end plate to be called on to release acetylcholine continuously, because again, the antibody doesn't give and take the way normally the receptor site would be operating. And as a result, I get a constant stimulation to release acetylcholine, and my patient is going to have a exhaustion of that motor end plate so that they can no longer utilize it. So I see in these patients long-term over time of the day exhaustion of the small muscles. I can see it in the droopy eyes and so forth. And I will deal with it with a pyrostigmine drug in order to stop the acetylcholinesterase inhibition. I can also do plasma exchange, IVIG plus thymectomy. All of these getting at removing the production of the antibody that's causing the problem in that tissue. Type 2 diabetes, I put in the chart, although I think it's actually a much better question from the biochemical point of view than it is from the immunological point. It's an antibody against your insulin receptor, which blocks the binding of insulin. So we manage this by behavior and diet modification, a wide variety of drugs that you'll go through in pharmacology. I think simply good enough to understand that it's an antibody acting as a binder to a receptor site, which is then causing the changed function of that end organ. The type 3 hypersensitivities are circulating immune complexes of antigen and antibody. So not whole cells, but they can be generated after I have cellular debris that results from other phenomena. These result in system-wide vasculitides because when my spleen is overwhelmed and unable to remove complexes from the blood anymore, then what happens is that those complexes will bind to small and medium-sized blood vessels, activate complement, and I will get system-wide fibrinoid necrosis any place that I have got those immune complexes binding. The model example of a type 3 hypersensitivity, of course, is systemic lupus erythematosus. And as you know, anywhere I've got small diameter blood vessels, in the kidney, in the joints, in the skin, I'm going to see the injury to the blood vessels. And the most visible sign, of course, is that lupus rash, which is what gives the disease its name. The rash that is over the cheekbones and causes additional photosensitivity. Now, in this case, lupus is a disease that we do not know for certain how it begins, But if you think about the fact that I'm making antibodies against double-stranded DNA and Smith protein as well as other nucleoproteins, I think it should stand to reason intellectually that this type of hypersensitivity has to follow some sort of cell death or damage. So there has to be an inciting event that causes inflammation and death in a tissue, which is then followed by the debris of that tissue being liberated and eligible for antibodies to be made against it. The DNA of our cells is naturally protected not only in a cellular membrane, but in a nuclear membrane. So it's not natural for these molecules to be exposed to the immune cells that would make antibodies. And yet clearly something happened in these patients that started the problem happening. And once it begins, of course, any death of any cell anywhere in the body is going to add more of that immunogen into the situation. I diagnose it by finding anti-nuclear antibodies, and of course there are criteria that are put forth by the American College of Rheumatology that are going to be more than that would be expected to be tested on the step 1 exam. Post-streptococcal glomerulonephritis is a condition, again, following infection with group A streptococci, so strep pyogenes again. But in this case, it follows either the pharyngeal infection, as we saw with rheumatic fever, or after streptococcal impetigo. Either of those previous infections are what will start this. And so I will make antibodies that will create granular deposits that will be visible in the kidney by immunofluorescence or electron microscopy. And the antibodies, again, are against the streptococcal wall antigens. These are post-streptococcal sequelae, so there's no real good evidence that the streptococci are still there, but the complexes have overwhelmed the ability of the spleen to remove. So, of course, we're going to have damage to the kidney and proteinuria and the finding of streptococcal enzymes in the blood. Other than that, we have the Arthus reaction, which is the one example of a localized result of type 3 hypersensitivity. Remember, all of the rest of them are system-wide, and I emphasize to you that that was a condition that you needed to be thinking about as you distinguish these from type 2. But in the case of the Arthus reaction, what is happening is that I am making a response to an injected material that I've seen before. So a very common scenario here would be someone who has received a booster of tetanus toxoid. Remember, I boost that vaccination at 10-year intervals. And as I do that, I can assume that there are still some memory cells left behind from the last booster. So there is some antibody being produced. And when I inject the protein antigen into that left deltoid, then the result will be the formation of immune complexes in the location, the activation of complement, and the damage in the area. So it can really happen against any injected protein, but I mentioned the tetanus booster because I suspect that each of you has remembered your last tetanus booster and the fact that the person delivering it probably should have asked you before they started which was your dominant arm. Because if they didn't, then you know that your arm that you use most was extremely sore at the injection site for about 12 or 24 hours. Okay? Beyond that, we have serum sickness, which honestly we don't see too much anymore. It's due to administration of some foreign protein. We used to see it in the First and Second World War when they would use animal serum as a plasma extender on the battlefield. Of course, lots of foreign proteins in that plasma extender. Nowadays, we don't see it so much from that, but we can see it following drugs. And it's normally about 12 hours to 3 weeks that I will see the symptoms after the history of knowing that something was administered. So notice in these last two that I've discussed, there's going to have to be some sort of history of administration of something. Then remember that anytime I have continuous presence of a viral pathogen in the context of a continued antibody synthesis, such as chronic hepatitis B virus, as well as chronic hepatitis C, then realize those immune complexes of antibodies against the virus are going to overwhelm the ability of the spleen, and they will cause immune complexes to be formed and do the damage that we eventually call periarteritis nodosa, panarteritis nodosa. So the treatment for that, of course, is to get rid of the virus if you can. Sometimes that's easier said than done. The type 4 hypersensitivities are the only ones that are mediated on the cell-mediated arm of the nirvana diagram. So they are a problem with the APC1, TH1, and cytotoxic loop. They can use macrophages as the end effector, because remember, I actually have 4 different types of effector on that arm of the immune response, but I don't involve natural killer cells because they don't have memory. And remember, hypersensitivities mean I have to have something that has memory of having done this before. Now, the reason for the timing, as I said in this case, is because it takes so long for cell-to-cell communication and activation and cloning and cytokine production to occur. So this is not a case where an antibody persists and is there then to cause problems subsequently. Now, the classic, perhaps model example of a type 4 hypersensitivity is the tuberculin test. And remember, we have analogous tests that can be performed for leprosy or any other facultative intracellular pathogen. Because really what you're measuring is the normal physiologic response to an organism that is living inside your APCs. The antigen is tuberculin and mycolic acid, which are surface molecules on the Mycobacterium tuberculosis organisms. If we're talking about the lepromin test, which is analogous, it would be surface molecules on the surface of Mycobacterium leprae. Notice what's going to happen is that I'm going to call in the cells that would create granulomas because of the fact that this is the antigen against which the sensitized T helper 1 cells are specific. So at the injection site, I would activate the previously sensitized T helper 1 cells, and they would call in and activate large numbers of monocytes from the blood or tissue macrophages, and basically cause the formation of a granuloma or an induration at that location. Now, it's truly not a granuloma in the pathologist sense of the word, because a granuloma is a morphologic diagnosis of a spherical accumulation of these cells, and this is not the way this is formed. There has been an artificial injection at the location. But I think it's handy to remember that if you think through the process, all of the manifestations of tuberculosis or the infection of any facultative intracellular are going to follow that same APC1, TH1, and then back to the APC stimulation. And so perhaps call it granulomatous, but it is an induration and not an erythema. Contact dermatitis, quite common against things that are very small molecules that can bind to our skin cells and act as haptens. So the molecule that incites the response is an oil or some sort of material. In cheap jewelry, which is coated with nickel to make it shiny, I can have a skin response as the nickel comes off of the jewelry and leaches onto my skin. And so the cells of my body end up being the carriers for the hapten, and I make an immune response against my own haptenated cells. So the effector cell in this case is going to be a cytotoxic cell that is called into the area to kill the altered cells. Okay? Rheumatoid arthritis is classified as a type 4 hypersensitivity. We're not certain what incites it, although certainly there are immunogens in the synovium to which the person begins to make an immune response. Notice that this is one of several examples where I can actually refer to this type of hypersensitivity as becoming one that is mixed over time. Because if you recall, I tried to emphasize to you that as I make a cytotoxic response using M1s and TH1s and cytotoxic cells, the debris that is formed by the killing from the cytotoxic cell can spill over onto the right-hand side of the pathway and create the M2 TH2 pathway and culminate in antibody production. So notice that I always classify these hypersensitivities based on what starts the problem. And it shouldn't surprise you with the complexity of the nirvana diagram that it's not at all uncommon to start with one arm and then have it spill over into the other. Now, our best diagnostic at this point, we always used to talk about rheumatoid factor, which are IgM antibodies against your own IgG. But nowadays, we're using more of the cyclic citrullonated peptides, which end up being more sensitive and specific of the problem. But long-term issues, destruction of the joints, tremendous amounts of inflammation reflecting the anemia of chronic disease. These are microcytic hypochromic anemias due to the long-term existence of the problem. And we deal with this by trying to get rid of the immune response. This is not a pretty problem. And persons who are treated for RA and most of the rest of the diseases that we'll talk about in this chapter are indeed on long-term, very heavy-duty immunosuppression. Hashimoto thyroiditis, to contrast with Graves' disease, which we already talked about. Remember, Graves' disease was a type 2 non-cytotoxic. Hashimoto's is a type 4 because cytotoxic T cells are going to kill thyroid cells, and so I'm going to have death of the cells leading to hypothyroidism. Okay? I also spill over onto the humoral side and end up making antibodies against the debris of the dead cells from the thyroid. So I diagnose this by measuring thyroid function, decreased thyroid hormone, increased TSH, and then of course finding those antibodies against thyroid peroxidase, which result from the activation of the other side of the immune response. Continuing on, we have pernicious anemia. Okay, realize in this case, I'm going to have cytotoxic cells which end up killing my parietal cells. So I hope it doesn't surprise you. In each of these remaining cases, I'm also going to have antibodies formed. They're classified as type 4 because what we believe starts the problem is the cell-mediated pathway killing the cells. But once the cells are killed, then the release of their contents is not surprisingly going to produce antibody formation. So in the case of pernicious anemia, I'm going to have a megaloblastic anemia. In the case of multiple sclerosis, I'm going to have demyelination, which is long-term. The antigen appears to be myelin basic protein. And in type 1 diabetes, what is destroyed is your islet cells that starts the process off. So I'm going to leave most of the rest of that, which is beyond my capacity to discuss with you, but I did do some research into this stuff so that you can look at it from the pharmacologic point of view. The remaining type 4s, I would know that they are classified as such, but I don't think we can answer a lot of questions about them due to the fact that we're not certain what starts the problem as far as the antigen, and we're certainly not sure what to do with them as far as therapy. But Guillain-Barré syndrome is a response to peripheral nerve gangliosides, an ascending paralysis. And remember, it does have an infectious disease component, that it is common to see Guillain-Barré after influenza and also after Campylobacter infections, probably because of molecular mimicry. In Crohn's disease, we're not certain. In celiac disease, it appears to be gliadin, and the cytotoxic T cells are actually responding to an MHC class 1-like molecule that starts off the problem with the molecular mimicry. So that brings us to a discussion of why autoimmunity happens. And honestly, we don't know. I think it shouldn't surprise you that most of these onset after childhood, because the master organ of your immune response, which controls self-tolerance, is of course the thymus, and the thymus is gone by the time an individual hits adolescence. So they tend to increase with age, and there are many triggers that we can't for sure outline, but hormonal, as you know, more common in females than males, environmental, genetic, infectious, molecular mimicry. And although I've mentioned this before, it's worth commenting that molecular mimicry just implies that some sort of microbe has a molecule that looks like something that your body has. And so a little bit of slippage of that recognition, and I end up making an immune response that then is continued by the presence of the immunogen in the form of my own tissues. Now, a lot is made about the association of various HLA types with autoimmunity. And I personally don't find this very much of a topic that I would encourage you to memorize. I know that there are lots of questions out there in a variety of different banks where they will ask you to very quickly regurgitate, if a patient has this condition, what is their most likely HLA type? And I've just given you a couple of points here, but my overarching theorem that I want you to take away from this is that unless knowing the HLA type of your patient is going to affect your diagnosis or your therapy of that patient, then I would argue that it does not fit the criterion of making me care. There are lots of questions in question banks that are simply not good questions, because any self-respecting physician would look them up if they needed to know the association, because honestly, it doesn't make a difference to how I treat the patient who has the given disease. Now, let me back off just a moment and say to you that HLA-B27 is a haplotype that has a constellation of diseases associated with it. And so realizing that if I have a B27 patient, I can anticipate seeing a laundry list of potential autoimmune problems. It doesn't mean I can necessarily explain that, but it does mean that the physician needs to be aware of the fact that finding one can mean another will develop. Okay? It's true, in fact, that in the case of ankylosing spondylitis, the identification of B27 is indeed involved in the diagnosis. So that is one exception to the normal rule. But in the great majority of autoimmune diseases, we do not bother to actually haplotype the patient at all because it makes no difference to our diagnosis or our therapy. If you'll notice, the other ones, other than B27, are mostly associated with DR. And I'm not going to belabor this because our current data comes in as percentages of increased risk. They do not expect you to memorize percentages of increased risk, so they're not going to ask you to say, is it 2 or 3 or 4? But I do think at least it is a principle of immunology, which happens to have a name, if you recall, and that name is the Rubush rule, that if I have a problem with MHC class 2, it is going to cause production of interleukin 2 or 4, and that's going to cause the problem to divide in 2. So it shouldn't surprise you, I think, that DR is a class 2 molecule. And there's got to be something about DR that predisposes it to presenting self molecules and causing that increase in the response through the cloning cytokines and the division of cells. That's all the further I would go. And honestly, if they were to test me on all of the HLA haplotypes, I would make a nasty gesture at them and say, I simply think you're wasting my time, because we do not use these medically as anything that would make a difference. Therapies are not pretty. Remember that I'm going to have to immunosuppress the patient in a drastic way. I will use something to inhibit proliferation like cyclosporin. I will use corticosteroids to decrease cytokine synthesis, or I will out and out kill T cells to stop the generation of the cytokines that causes the problems to get worse. Now, it's true recently, of course, that the absolute explosion of development of new biologics is revolutionizing our management of these problems. And the only thing I want to say about these is that at least you can tell that something is a monoclonal if it has the last letters in the name of the drug being MAB. Okay, that stands for monoclonal antibody. Now, if you recall, we talked about the fact that immunoglobulins are glycoproteins, so they are immunogenic. And if I create a monoclonal antibody and I inject it repeatedly into a patient with good intentions to ameliorate their symptoms and signs, the problem is that I can make an immune response against that monoclonal when I start to recognize it as a foreign protein. So what I give you here is simply a list of the nomenclature of the monoclonals so that you can notice that we try to reduce the amount of the molecule that could actually be recognized as being foreign. And so each of these individual pairs or tetrads of letters in the middle of the word will tell you the source The ones that are most likely to cause an immune response that would be deleterious would be the ones made in mice, entirely different species. When we get down to the ones that are both chimeric and humanized, notice there's only one part of that molecule that is foreign, and that is actually the idiotype. So if I were going to make an immune response that would damage me after I was repeatedly injected with one of those, I would have to be making an anti-idiotype antibody. And those really would not happen except over years and years and years, because the idiotype, remember, is the three-dimensional shape of the combining site. And it's just such a minute portion of the molecule, which in good situations would be bound to its antigen anyway. All right. In summary, going back to the sort of scheme of the immune response, realize that all of the hypersensitivities except one are a reflection of the humoral side. That I would have an APC2 delivering the signal to a T helper 2 and culminating in humoral immunity. Type 1 is done by IgE. 2 and 3 are IgM or IgG antibodies, most commonly IgG. And type 4 hypersensitivity is the only one that involves the APC1 signaling to the T helper 1 and causing the activation of the effectors of cell-mediated immunity. Now, additionally, remember that turning on Th17 cells becomes a do loop that causes recruitment of more and more neutrophils. Neutrophils in and of themselves are damaging, and so I completely continue to create debris, which eventually, as we said, can spill over into production of antibodies as well. Again, I didn't have any hashtag make me cares here because of the fact that this is a very heavily tested chapter, both pharmacologically and physiologically and immunologically. Make certain that as you review this chapter toward the end, you feel comfortable going through all of the specifics of each and every one of these and thinking of the scenario in which you would make the diagnosis of the patient.